Hello guys, I'm Deepak Shukla. Today let's learn about juvenile nasopharyngeal angiofibroma. JNA is a benign tumor exclusively seen in males, that is in juvenile age group, and it is a fibrovascular tumor, that is tumor filled with lots of blood vessels. It is rare, but among nasopharyngeal tumors it is most common. It is exclusively seen in males and requires testosterone for its growth. So it is seen in pubertal males. So if there is any focus already present, that will cause spurt of testosterone in puberty that can lead to GNA. Okay, so the most common site of origin of GNA is sphenopalatine foramen. So sphenopalatine foramen is the most common location of GNA. Okay, and that is near posterior wall of maxillary sinus, 8 to 10 millimeter from middle terminate. Other sites of origin are anterior wall of sphenoid sinus, roof of nasopharynx, and lateral wall of nasopharynx. So here you can see it is growing posteriorly in the sphenopalatine foramen. Okay. Let's see some points about pathology. Endothelium is lined blood vessels without muscularis. Okay. So I mean to say that blood vessels are lined by endothelium, but there is no muscularis layer. No vasoconstriction, no effect of adrenaline. Therefore, since these things are not there, so this will cause recurrent, unprovoked, profused epistaxis. So we cannot do biopsy in this case. So need not to do FNSC, probe test or digital palpation in GNA. It is contraindicated. GNA, though benign, it does not have capsule, so it is non-encapsulated and it is also locally invasive. Okay, so since it is benign, but then too it is non-encapsulated and locally invasive, so you have to keep this in mind. Let's learn about clinical features. So I've told you that it is a highly vascular tumor, so bleeding will be there. So how to define this bleeding? It is recurrent, profuse, unprovoked epistaxis. Okay, a recurrent, profuse, unprovoked epistaxis, and multiple episodes can be seen, and this will lead to anemia. Okay, so this is the first clinical feature. Second one is obstruction. So it can cause nasal obstruction, and if it causes nasal obstruction, you can see the frog face deformity. Okay, when tumor grows anteriorly, so you can see the nasal obstruction, and here you can see the frog face deformity. If it causes ET tube obstruction, eustachian tube obstruction, if it is unilateral, it can cause serous otitis media and conductive hearing loss. So in children, the differential diagnosis, you should always think of GNA, but in adults you have to think of nasopharyngeal carcinoma. For bilateral obstruction, there are so many causes, but for unilateral, you have to think for GNA in children and nasopharyngeal carcinoma in adults. Then hyponasal speech due to nasal obstruction can also be seen. So what features you'll see in frog face deformity? You'll see the swelling of cheek, proptosis, and widening of nasal bridge. Okay, swelling of cheek, proptosis, nasal obstruction, and widening of nasal bridge. Now, if it spreads to superiorly into the sphenoid sinus and cavernous sinus, you can see second, third, fourth, fifth, and sixth cranial nerve palsy. So this was regarding pathology and clinical features of GNA. Now coming to examination. On simple anterior rhinoscopy, you can see globular pink mass in posterior part of nasal cavity with septum being pushed to opposite side. In posterior nasal examination that is done using a mirror to confirm, there is pink to purple globular mass with dilated blood vessels. Again, keep in mind that probe test and distal palpation is contraindicated. Now let's know how to evaluate GNA. So first you have to take the history, and history is the mainstay and examination. Then go for CECT. CECT is the investigation of choice, and we can do contrast enhanced CT, okay, because it is highly vascular. So to confirm about malignancy, we cannot do biopsy. I have already told you we cannot do biopsy since it bleeds profusely. Instead, we have to do CECT. So being vascular, the tumor takes contrast dye very quickly, and extent of spread presence of any bone erosion can be made out. So CECT is the investigation of choice. Okay, you can write X-ray of neck, and that to lateral view, and X-ray of the paranasal sinuses if CT is not available. MRI is done for any intracranial involvement, okay, like carotid or cavernous, so MRI can be done. Angiography has to be done to know the feeding blood vessel, like which blood vessel is feeding that tumor. And most commonly, if you'll see the feeding blood vessel is external carotid artery, and that too internal maxillary artery is the most common feeding blood vessels of GNA. And after angiography, you can embolize the external carotid artery or whatever artery that is feeding the tumor. If blood supply is internal carotid artery, you should never embolize it, okay, because internal carotid artery that will supply to brain also, so you should never embolize this artery. So these are some examinations that you can do, okay, CECT, X-ray, MRI, angiography. Now coming to signs that you'll see on X-ray, the first sign is Hallman-Miller sign, okay, since it is in the sphenopalatine foramen, okay, so it pushes the posterior wall of maxillary sinus anteriorly, okay, so there is bending of or pushing of posterior wall of maxillary sinus anteriorly, and that is called Hallman-Miller sign, that is pushing or bowing of posterior wall of maxillary sinus anteriorly. So here you can see this, because of the tumor that is pushing the posterior wall of maxillary sinus. Second, we have Hondusa's sign, so increase in distance between the posterior wall of maxilla and mandible, okay, so there is distance between the posterior wall of maxillary sinus and mandible has been increased. And the third one is opacification of sphenoid sinus. So these are the signs in X-ray. In CT scan, due to erosion of pterygoid bone and mass in nose and pterygopalatine fossa, you can see the chopstick sign, okay, so earlier it was like this is medial and this is lateral and this was joint, but here due to erosion of this there is removal or separation of this medial and the lateral wall of the pterygopalatine fossa, that shows the chopstick sign. So remember that chopstick sign is seen in CT scan. So erosion is behind the sphenopalatine foramen at the roof of pterygoid plate, okay. In MRI, assess the relation of tumor to the critical structures like internal carotid artery or cavernous sinus that I already told. Recurrent and residual tumors are best appreciated in MRI. Angiography will tell about the specific blood supply of tumor. The most common blood vessel supplying the tumor is internal maxillary artery, and then it can be useful, this angiography is useful for embolization. So I have told you that internal maxillary artery is the most common feeding blood vessel for the JNA, and other vessels include ascending pharyngeal artery. So we have to block this artery, then the tumor will become avascular and then we can go for excision. Normally, the biopsy is contraindicated, but there is some exception, okay. So exception is only when radiotherapy is contemplated, we have to go for biopsy, okay, because the tumor is inoperable, so we have to do the biopsy. So biopsy is done or tissue diagnosis is done before the starting of radiations, okay. So we take biopsy with all precautions in case bleeding occurs, okay. So we have to take all the precautions in case bleeding occurs. So this concludes about all the investigations: MRI, angiography, CT scan, X-ray. Now coming to the staging of this GNA, we have Radkowski's classification. This is the modification of Sisson's classification, okay. So here we have stage 1A, 1B, 2A, 2B, 2C, 3A and 3B, okay. So if you keep in mind the severity, you can aram se write the staging. Stage 1A is limited to nose and nasopharyngeal area. Stage 2B is extension up to one or more sinuses. Stage 2A, now there is minimum extension up to pterygopalatine fossa. Now stage 2B is occupation of pterygopalatine fossa with or without orbital erosion, okay. So you can see now there is pterygopalatine fossa is occupied and there is orbital erosion present or not, okay. In 2C, intratemporal fossa extension is there with or without pterygoid plate involvement. In 3A, erosion of the skull base, mainly middle cranial fossa or pterygoids, and in 3B, erosion of skull base with intracranial extension with or without cavernous sinus involvement. So this is about the Radkow's staging of JNA. Now coming to the treatment part. For sure we have to go for surgery, but before that we have to do pre-operative embolization to decrease the vascularity, okay. So we have to go for pre-operative embolization to decrease the vascularity. So embolization is done 24 to 48 hours before surgery, okay, and a course of estrogen therapy is given, that is stilbestrol 2.5 mg thrice daily for 3 weeks, or you can go for cryotherapy. So these things are done before the surgery to decrease the vascularity of the tumor. Surgery can be done by external approach, that is mid-facial degloving, or transpalatine approach, sublabial approach, and endoscopic intranasal approach. So these are the approaches for the surgery. What are the indications for radiotherapy? When you cannot do the surgery but you can do radiotherapy, okay. So whenever there is intracranial involvement, you can go for radiotherapy. Or if the feeding blood vessel is internal carotid artery, you cannot embolize it, so you will go for radiotherapy. Okay, so first thing is intracranial involvement, second is direct blood supply from the internal carotid artery. Okay, then unresectable disease, so you cannot resect that, and multiple recurrences may be good candidates for radiation treatment. Okay, so if it is multiple recurrence, you have to go for radiotherapy. So with radiotherapy, recurrence rate is 20 to 30%. Some newer techniques in radiotherapy treatment such as intense modulated conformal radiotherapy, okay, and gamma knife have shown good results. Coming to hormonal therapy and chemotherapy, we have diethylestilbestrol. Diethylestilbestrol, it is a estrogen therapy with flutonide, because of it is testosterone dependent. Okay, since it is testosterone dependent, so we are giving estrogen therapy. And chemo for residual or recurrent diseases, doxorubicin, vincristine, and dacarbazine. So this was about the treatment of JNA. Thank you so much.